Hello everyone. Now we are covering chapter 25 is acid and base homeostasis and imbalance. Acid and base homeostasis and imbalance understands normal mechanism of acid and base homeostasis contributing to understanding the acid and base imbalance. pH of a fluid reflects its degree of acidity or alkalinity. Cellular functions is impaired when the pH of body fluid becomes abnormal. The normal pH in blood is from 735 to 745. High pH indicate few hydrogen ions. Solution is alkaline. Low pH indicate a lot of hydrogen ions. Solution is acid. pH is blood of other body fluid becomes too acid or too alkalotic, dysfunction and even death can occur. Death can occur if pH falls 6.9 or raise 7.8. Maintain of acid and base imbalance reflects homeostatic functions of normal cell metabolism. Three major mechanisms regulate the acid and base status of body: buffer, respiratory system, and renal system. Altered AVG measures are useful indicator of acid base status of extracellular fluid. That's how we know if the patient have a problem in the acid and base with the AVG. We measure the PaCO2 is the amount of CO2 in the blood and is driven by the respiration. Bicarbonate HCO3 is related with metabolic and renal. pH indicates net result of normal acid-base regulations, any dysfunction of pH regulations, body compensatory response, and does not reflect pH inside the cell or cerebrospinal fluid. Buffers. First line of defense against pH changes in all body fluids, chemicals that help to control pH of body fluids. Components: weak acids that release hydrogen ion when a fluid is too alkaline, and base that take up hydrogens when fluid is too acid. Type of buffer: we have bicarbonate, phosphates, hemoglobins, and proteins. Primary defense mechanism: acid and base disorders. Defense against acid and base disorders. Most important buffer in extracellular fluids. Components: base, bicarbonate, weak acid, carbonic acid, and maintain in chemical equilibrium in extracellular fluid. 20:1 ratio of bicarbonate ion to carbonic acid necessary for a normal pH. Function: too much acid, lactic acid, acidic. Bicarbonate ions take up hydrogen ion released by the acid, become carbonic acid. Carbonic acid release of carbon dioxide through the lungs. Too little acid, alkaline bicarbonate buffer release hydrogen ions from weak acid to increase pH. Second defense mechanism. Second defense against acid and base disorder. Lung excretion CO2 and water from body. Rate of body of carbonic acid, change in rate and depth of respiration result from a stimulation of chemoreceptor that sends PaCO2 and pH of blood. Exerts an influence of and serves to alter amount of PaCO2 and carbonic acid in blood. Excessive carbonic acid accumulations, increased rate of depth of respiration, excessive carbonic acid remove, and insufficiency carbonic acid. Respiratory rate and depth decrease, allow for temperature accumulate and carbonic acid. temporary accumulate of carbonic acid. Listen, in other words, the regulation of acid and base is by the respiration and by the renal, okay? Those are compensation, okay? Respiratory compensation is faster than metabolic compensation because you just change the respiratory rate. If you increase your respiratory rates, you get rid of the CO2, and then you raise your pH. If the pH is high, that is alkalotic, then you start breathing slowly, you start retaining CO2, and then you lower the pH. Increased ventilation, hyperventilation result in decreased carbonic dioxide in the blood, thus reduce carbonic acid. Decreased ventilation, hyperventilation, carbon dioxide accumulate, thus increase carbonic acid. PaCO2 levels indicate how effectively the respiratory system is excreting carbonic acid. The lung can excrete only carbonic acid, they cannot excrete non-volatile acid, lactic acid and acetic acid, non-volatile acid. Compensation. Respiratory response to an imbalance of any metabolic acid, except carbonic acid. Compensatory response does not correct a pH disorder, does compensate for it by adjusting the pH back toward normal. Other blood chemistry values are made anormal in the process. Compensation, compensatory response, deficit of any acid except carbonic acid is hypoventilation. Excess of any acid except carbonic acid is hyperventilation. For an imbalance of metabolic acid begins in minutes, require at least several hours to full effectiveness. Kidney. Third, defense against acid and base disorder. Can excrete any acid from the body except carbonic acid, solely excreted by the lungs. Excreted metabolic acid produced continues during normal metabolism. Body's ability to correct an excess of deficit of metabolic acid depends on normal function of renal system. Increased excretion of hydrogens if a metabolic acid begins to accumulate in blood. A slow excretion of hydrogen if metabolic acid is deficiency in blood. Increased excretion of hydrogens, increased production of ammonia. Hydrogen combines with ammonia and is excreted in the urine. A slow excretion of hydrogens, decreased production of ammonia, excrete less hydrogens, reabsorb hydrogen back into the blood, excrete bicarbonate. Bicarbonate in plasma reflect the effectiveness of renal regulation of metabolic acid, reflects the relative amount of metabolic acid in the blood. Decreased bicarbonate indicate a relative excess of metabolic acid. Metabolic acids are accumulating into the blood, buffered by bicarbonate. Bicarbonate concentration will drop below normal. Increased bicarbonate indicate a relatively defect in metabolic acids. In other words, a relative excess of base. Compensation. Renal response for carbonic acid imbalance. Compensatory response for high carbonic acid levels increase the excretion of metabolic acid and hydrogens. For low carbonic acid level, decrease the excretion of metabolic acids and hydrogen excrete bicarbonate. Require several days to fully operative. That means that the respiratory compensation is faster than the metabolic compensation. 4 primary disorder: metabolic acidosis, respiratory acidosis, metabolic alkalosis, and respiratory alkalosis. Other disorder is a mixed acid and base imbalance, and those are the most common ones in real life. This one. Oh, sorry. The most common one are the mix. Okay, we have question number 1, and then a patient have a deficit of carbonic acid. How will the patient body compensate? And the answer is A. The kidney will decrease the excretion of metabolic acid and hydrogens. Acid and base imbalance. Acidosis is a present of condition that tends to decrease pH of blood, making it more acidic. Alkalosis is the presence of factors that increase pH of blood above normal, making it more alkaline. Metabolic acidosis is relative excessive of any acid except carbonic acid. May be caused by increase in acid, excess removal or decrease in base, combination or increase in acid and decrease in base, result in decrease of normal 20 to 1 ratio of bicarbonate to H2CO3. Increase in acidity, decrease normal ratio of bicarbonate to carbonic acid because bicarbonate ions are used up in buffering that accepts acids. Example, starvation ketoacidosis, caloric and glucose intake is insufficiency, body begin to use fat storage for energy, fat metabolized incompletely, keto acid accumulate in blood, causing metabolic acidosis. Increase in acid, other example, ketoacidosis in diabetic ketoacidosis, severe hyperthyroidism, burns, circulatory shock, tissue anoxia, oligurin renal failure, intake of acid or acid pressures, sample salicylate, methanol, ethylene glycol. Excessive removal or decrease in base, that's metabolic acidosis. Going metabolic acidosis, excessive removal or decrease in base, anything that causes a remove decrease in bicarbonate, example, diarrhea, gastrointestinal fistula, and renal tubular acidosis. Those are samples that produce a condition that can produce metabolic acidosis. Clinical manifestation: headache, abdominal pain, central nervous system depression, confusion, lethargy, stupor, coma. Clinical manifestations: severe metabolic acidosis, tachycardia, ventricular arrhythmia from myocardial intracellular acidity, decreased cardiac contractility, death from brain dysfunction usually occurs the pH falls below 6.9. Clinical manifestation: uncompensated ABG, below normal bicarbonate concentration, pH below normal, normal PaCO2. Compensatory response: hyperventilation is typical respiratory compensatory response. Low blood pH stimulate peripheral chemoreceptor. Ventilatory neurons respond to increased rate and depth of respirations, result in increased excretion by lung of carbonic acid, carbon dioxide. Compensatory response does not remove metabolic acid from body, thus change ratio of bicarbonate ion to carbonic acid, result in compensatory increase in pH. Compensatory arterial blood gases. Uncompensated metabolic acidosis show decreased bicarbonate concentration, primary disorder, decreased PaCO2 compensations, decrease somewhat low or even normal pH depending on the degree of compensations. And we have question number 2. Which of the following will be associated with metabolic acidosis? And the answer is A. Central nervous system depression. Respiratory acidosis, any condition that causes an excess of carbonic acid, caused by impaired removal of carbonic acid by the lungs, impaired gas exchange, inadequate neuromuscular functions, impaired respiratory control in the brainstem, decrease the normal 20:1 ratio of bicarbonate ion to carbonic acid, impaired gas exchange, chronic obstructive pulmonary disease, COPD, pneumonia, severe asthma, pulmonary edema, acute respiratory distress syndrome, inadequate neuromuscular junctions, Guillain-Barré syndrome, chest injury or surgery, hypokalemic respiratory muscle weakness, severe kyphosis, respiratory muscle fatigue, impaired respiratory control, respiratory depressant drug, opioid barbitrates. Clinical manifestation, we have headache, tachycardia, cardiac arrhythmia, neurologic abnormality, blurry vision, tremor, vertigo, disorientation, lethargy, somnolence, severe respiratory acidosis, peripheral vasodilation with hypotension. Clinical manifestation, uncompensated AVG. PlCO2 above normal, pH is below normal, and bicarbonate normal. Respiratory acidosis, compensatory response, increased renal excretion of metabolic acid, kidney cannot excrete carbonic acid. This is solely respiratory functions, excretion of pH and retention of bicarbonate result in increase of bicarbonate ions, movement of pH toward normal, requires several days to be effective. Remember that respiratory problems, the compensation is by the kidney. That's why respiratory problems, the effectiveness takes days. In metabolic process, the effectiveness is faster because the compensation is respiratory. Compensated arterial blood gases in compensated respiratory acidosis show increased PaCO2, primary imbalance, increased bicarbonate concentration, that's the compensation, and decreased or even normal pH, depending on degree of compensation. And we have question number 3. Question number 3, a blood gas report shows the following: pH 7.3, PaCO2 51, and bicarbonate 23. Which of the following conditions could produce this result? Okay, first of all, you have to know that right here we have an acidosis. Okay, let me see if I can explain this. Okay, let me go back. Okay, right here we have acidosis. Okay, acidosis because the pH is 7.3, that means that is lower than 7.4. Then we have to know which one is contributing to that acidosis. As you go right here, the PaCO2 is 51. That one is a little bit high. Bicarbonate in 23 is normal. It's a normal bicarbonate. That means that the acidosis comes from the lungs. Okay. In this case, we have a respiratory acidosis. Okay. And then out of all those options right there. The only one that is with lungs is pulmonary edema, and that's produce respiratory acidosis. Metabolic alkalosis, any condition that tends to cause a relative deficit of any acid except carbonic acid, causes increase in base bicarbonate, decrease in acid, and combination of the two. Increase in base, intake of bicarbonate or bicarbonate. Precursors: acetate, citrate, and lactate. Massive transfusion with citrated blood, mild or moderate extracellular fluid volume deficits. Decrease in acid, emesis, gastric suctions, mild or moderate extracellular fluid volume deficits, contractions alkalosis, hyperaldosteronism, hypokalemia. This is extremely important. Emesis. Okay? Now we have a case. Let's see what happened right here. We were right here. We already finished question number 3. Acidosis, emesis. Then clinical manifestation, we have postural hypotensions, hypokalemia may coexist, bilateral muscle weakness, potassium shift into the cell, increased neuromuscular excitability, tingling, finger and toe, sign of tetany, may progress to seizure, ionized hypocalcemia, calcium bind to albumin, contributing to the excitability. Clinical manifestations: increased excitability of nerve cell membrane, beligerins, severe metabolic alkalosis, central nervous system depression, confusion, lethargy, coma. Death usually occur if the pH raises to 7.8. Clinical manifestations: we have uncompensated AVG, bicarbonate concentration is elevated, that's why it's metabolic alkalosis. PaCO2 is normal or low because that's the compensation, and pH is above normal. Compensatory response: hypoventilations, usually incomplete. Need for oxygen drive ventilation and prevents complete compensations. Hypoventilation, because remember that if you are alkalosis, that means that the pH is high, that you have low concentration of hydrogens, you need an acid. And how do you get an acid? Because of hypoventilation. Then you accumulate CO2 and then you lower the pH to the normal levels. Compensated arterial blood gases in compensated metabolic alkalosis show increased bicarbonate concentration, primary imbalance, increased CO2 compensations, and a slight increase in pH. Respiratory alkalosis, any condition that tends to cause carbonic acid deficits, cause hyperventilation, hypoxemia, acute pain, anxiety, physiological distress. That's why acute pain produces respiratory. That's why when you have a patient that is in pain, you have to give painkiller, because if you don't give painkiller to those patients, then they are going to develop respiratory alkalosis, and that's another complications. Anxiety, physiological distress, prolonged sobbing, alcohol withdrawal, stimulation of the brain stem, salicylates, that's aspirin, salicylates overdose, meningitis, headache, gram-negative sepsis. Clinical manifestations: increased neuromuscular excitability, paresthesia, carpal and pedal spasms, decreased ionized calcium, which contributes to the excitability, increased central and peripheral membrane excitability. Clinical manifestations: increased pH of cerebrospinal fluids and cerebral interstitial fluid, altered brain cell functions, can cause confusion or excitations, cerebral vasoconstrictions. Clinical manifestations: uncompensated AVG, PaCO2 to be abnormal low, pH is abnormally high, and bicarbonate is normal. Compensatory response: decreased renal excretion of metabolic acid, retention of hydrogen by the kidney, decrease in bicarbonate ion concentration, kidney excrete bicarbonate. Compensatory response: renal compensations tend to return the ratio of bicarbonate ions to carbonic acid, moving pH toward normal. Because this takes several days and because many cows are short-lived, may not be fully compensated. Compensatory arterial blood gases in compensated respiratory alkalosis show decreased PlCO2 primary imbalance, decreased bicarbonate concentration, that's the compensations, and increased pH. Two primary imbalance occur simultaneously. Example: a patient with bacterial pneumonia and related respiratory acidosis also develops severe diarrhea and concurrent metabolic acidosis, usually have a very low pH. Two types of primary acidosis or alkalosis may impair effectiveness of usual compensatory mechanisms. Mixed acid and base imbalance: pH will reflect primary mechanism, either acidosis or alkalosis, may also occur with a nearly normal pH if the primary acidosis and primary alkalosis are involved. Example: head injury, respiratory alkalosis, along with metabolic acidosis from kidney injury. Neonates often have a mild metabolic acidosis. Infants younger than 1 month are at risk for metabolic acidosis when they have a condition that results in acid accumulation, reduced ability to excrete large acid load, kidney less able to reabsorb bicarbonates, produce less ammonia, and urinary buffer are limited in quantity. Teens with eating disorder may develop metabolic alkalosis from repeat emesis and hypokalemia, metabolic acidosis from starvation, or laxative-induced chronic diarrhea. Geriatric variation: delay ability to correct respiratory acidosis based off age-related decrease in chemoreceptor response to increased PaCO2. Increased risk of respiratory acidosis from barbiturate because of increased drug half-life, are at risk for metabolic acidosis, kidney less able to excrete large acid load, chronic laxative overuse that result in chronic diarrhea. And right here we have a clinical case. That case is for you to study, and all the answers are right there on the original PowerPoints, and all the original PowerPoints are in Blackboard in the instruction block. Okay, and we finish right here with this PowerPoint.